Hello, everyone. Good morning, good evening, good afternoon to all attendants globally. We are here with a very interesting webinar. The landscape of the treatment of obesity is changing, and it's a fast pace. We have several different options to treat clinical obesity today. We have modern pharmacotherapy, obesity management medications, we have endoscopy and surgery. And most important, we need to hear the patient's voice on all those options that are available. So the title of the webinar, it's Obesity Care Without Borders. So we're going to approach different strategies for the best outcomes for our patients. Thank you very much for this esteemed and world-class faculty with us. And we're going to start with the first presentation by Mr. James James Zervios. James Zervios is the Obesity Action Coalition Chief Operation Office, and he'll present us his views on the multimodal approach to obesity today. And then we're going to follow two other lectures that I'll present the speakers as soon as they begin the lecture. Thank you very much.
Hello, my name is James Zervios, and I'm the Obesity Action Coalition's Senior Vice President and Chief Operating Officer. I'm excited to be here with you today to talk a little bit more about patient needs in the obesity space. For those of you not familiar with the Obesity Action Coalition, the OAC is a 501c3 national nonprofit organization dedicated to educating and advocating for individuals affected by the disease of obesity. We currently have more than 90,000 members nationwide, and our mission is to elevate and empower those affected by obesity through education, advocacy, and support. As an organization, we operate under 5 key pillars: education, awareness, advocacy, support, and research. And under each of these, you'll find a lot of different content, campaigns, and work that we do as an organization that at the end of the day really exists to improve the life of people affected by the disease of obesity. So when we talk today about patient needs, we say that the OAC believes that patients with obesity need and deserve access to evidence-based care, respect, dignity, and bias-free healthcare, education and trusted information, empowerment and patient voice, mental health support, policy protections and legal equity, community support and advocacy opportunities. And we'll talk about each of these in a little bit more. So when we talk about access, we're talking about access to comprehensive evidence-based care. Patients need access to the full range of science-based obesity treatments, including behavioral, medical, and surgical options. This includes obesity medicine specialists, nutrition and mental health counseling, intensive behavioral therapy, obesity medications, and metabolic and bariatric surgery. OAC emphasizes that insurance coverage and affordability are essential to ensure individuals can access these options. While we have many effective treatments for obesity these days, we still struggle significantly with individuals being able to access them, especially through insurance. And so this is a really key area that the OAC continues to work on, both at the state and the federal level here in the US with legislation, and then also with private insurance as well. Next, we have respect, dignity, and bias-free healthcare. People affected by obesity need to be treated with respect and without stigma or discrimination in the healthcare settings and society. Weight bias can negatively impact both physical and psychological health, and eliminating this stigma is a central advocacy priority for OAC. This includes respectful communication in people-first language, providers trained to discuss weight and health appropriately, and clinical environments that accommodate patients of all sizes. Ironically, healthcare is one of the places that people with obesity report weight bias and stigma the most. And when we talk about this, it can be in many forms. It could be the blame that's often put on people with obesity by a clinician saying, it's your fault, you did this to yourself. It can be not having proper equipment, so a blood pressure cuff for a person of size, proper seating, proper exam table, so on and so forth. All of these things really should be standard in a healthcare setting when you're dealing with the disease of obesity. By not having them or not talking about it the right way, unfortunately, we're really emphasizing that stigma and bias that people with obesity have felt and dealt with pretty much all their life. Education and trusted information. Patients need reliable, science-based education about obesity, its causes, and available treatments so they can make informed decisions about their health. OAC emphasizes providing resources on obesity science, treatment options, nutrition and physical activity, mental health, and behavioral strategies. Today, there is a significant amount of misinformation that's out there, especially online, for people searching for resources to help them with their weight and health. OAC prides itself on having science-based education to really help that patient, that person, make an informed decision about their weight and health. Empowerment. So empowerment and patient voice. People affected by obesity need the ability to participate in decisions about their healthcare and have their experiences represented in policy and research. OAC promotes patient-centered care decisions between individuals and providers, inclusion of people with obesity in research and policy discussions. So for far too long, people with obesity have been excluded from a lot of these areas. But it's really important that we include people with this disease in these processes, in these decision-making opportunities, so that they feel represented as well. Mental and emotional health support. People affected by obesity often experience stigma, shame, and psychological stress, making mental health support an important component of care. Patients need counseling or behavioral therapy, body image support, coping strategies for stigma, and trauma-informed care. This is an area that's often overlooked when it comes to obesity treatment. We tend to go straight to either the number on the scale or even the related conditions and look for resolution in those or that number going down. But the truth is that we really need to address mental health as well. This is an area that's very important for people dealing with obesity. We know the journey of weight and health is very much up, down. You may gain weight, lose weight, life events can happen, and this is really where that mental health support comes in and is really key. Policy protections and legal equity. Patients need legal and policy protections that prevent discrimination and expand access to treatment. This includes anti-discrimination protections, insurance coverage mandates, fair treatment in employment, education, and healthcare. And we actively advocate for all of these protections. This is very important as people with obesity, as we've said many times, are often discriminated against. And for example, in the employment setting, if we don't have these protections for people, that discrimination will only continue. Community support and advocacy opportunities. Patients need support systems and opportunities to connect with others who understand their experiences. OAC provides peer community spaces, educational events, advocacy engagement opportunities, and platforms to share lived experiences. This is one of the most key components of the OAC. It's who we are at our core, and it's a very, very strong need for individuals dealing with obesity. We often say that when people first find out about OAC and come to the organization, they often say, I finally found my people. I finally found people that understand what I'm going through. And this is incredibly important as people with obesity often feel isolated and kind of pushed out of society. So OAC provides this opportunity for support and advocacy as well for people. It's always kind of the thought that people come to OAC first to help themselves and then over time become essential active advocates for change. And they can do that through a wide variety of ways, whether they're fighting for access to care, weight bias, coming to our in-person events such as our national convention, or even our regional events, but really finding themselves and then finding that community as well. And lastly, here we have a nice graphic that kind of summarizes what we've talked about today. We've talked a lot about weight bias, the patient voice, community support, and disease management. But if you look at the center of all of it is the person affected by obesity, or the people affected by obesity here in this graphic. And this is incredibly important. OAC is very patient-centric, people-centric at the end of the day. All that we do in all of the areas we focus, education, advocacy, support, and research, is for the person impacted by the disease of obesity. Even though you have a significant amount of people all around the world that are dealing with this disease, their needs are often not represented. And they're not represented in a lot of areas, be it employment, healthcare, the educational system, so on and so forth. It's really crucial that we take note of this and that we ensure that they are a part of the conversation, they are part of the decision-making process, and that their needs are represented, especially when it comes to their healthcare and managing their weight and health. Thank you very much for taking the time to listen to this presentation today. I appreciate your time.
Excellent, excellent presentation. We just saw what the patient needs, and the next presentation will be by Professor Alex Miras, a very good friend. He's professor of endocrinology at the Ulster University in the UK. Please remember who's watching us in this webinar that we have a chat button in the bottom of your screen. All questions can be added there, and we'll do our efforts to respond them accordingly. Please, Alex.
Hello, and thank you very much for the opportunity to contribute to this IFSO webinar. My name is Alex Miros. I'm an endocrinologist practicing in the UK. And what I'll do is I'll show you some data that will hopefully convince everyone that not only should we be working together, we are forced to be working together because the data and the patient benefit is there to be gained rather than any form of competition. These are my disclosures. It is true that at the moment we are living at this hype of pharmacotherapy. It's a new technology. There's a huge amount of excitement, even without much reason sometime. We will reach the peak of this excitement. Soon there will be a drop in this interest to the point of disillusionment, even with this technology, possibly because of side effects and unmet needs. But then we will come to our senses, and eventually we will use the pharmacotherapy technology productively in the appropriate place and together with other therapies rather than on its own. Now, I can fully understand why there is so much interest in medications. Have a look at from this graph as to how much at least weight loss we can achieve with these therapies. We have surpassed the amount of weight loss, mean weight loss, that a sleeve gastrectomy would typically do based on the best RCTs in the field, which is around 20%. And now we're getting closer to the 25% mark, which is what a gastric bypass would typically do, again, based on the BIBANT trial. But let's talk about how what are the needs and where are the spaces where we could be working together. So the first one would be with the use of pharmacotherapy before surgery. We all appreciate that the risk of death after surgery is very, very low. Yet, despite that, in relative terms, the higher the body mass index, there is a dose response curve in that people with very high BMIs have got a much significantly higher risk of mortality independently of the model that's being, statistical model that's being used to calculate that. And in addition to that, we also know that again there is a dose response curve in terms of weight loss and its effects on mortality, with a more than 10% weight loss achieving the highest outcomes in terms of reducing the mortality in relative terms, as unusual as this event rate as this observation is, which is death. So again, this is coming from large cohort study. This is not an RCT, but I think provides some evidence to support the use of weight loss, at least for mortality reduction. And we've got a meta-analysis of studies that was done a few years ago, which shows a reduction not only in mortality, but in 90 days perioperative outcomes. And again, perhaps not strong RCT data, but pretty convincing amount of information to tell us that we should be doing something before surgery. Where do the benefits come from? Well, that is a little bit unclear because the data on intraoperative outcomes and complications and hospital stay is not that consistent and strong. We probably have got stronger information when it comes to the risk of postoperative complications, more specifically leaks, infections, and wound complications. How can we facilitate weight loss? We know that even a short amount of caloric restriction for a couple of weeks can be enough to improve cardiometabolic health in patients that are at high risk. But if we want to start achieving 5 or 10% weight losses, then this caloric restriction will have to take place over a longer period of time, probably 6, 8 weeks or even longer. Difficult to maintain, but not impossible. Or we could use pharmacotherapy agents to reduce weight. We don't have, again, no RCT data on that, but makes clinical sense. Any data that we have comes from the older medications that we were using. So we could use this approach for 6, 9 months or whatever, and use it as a bridge towards surgery. Or we could use endoscopic therapies like gastric balloons. We can achieve also pretty good outcomes, again, as a bridge. I think the question that often we're asked is, should we be doing this in everyone? And I don't think that it makes sense to be doing that. There will be people of low BMIs, of low medical complexities that should just go ahead and have their operations rather than delaying them. On the other hand, there will be people of high body mass indices or complex cardiometabolic or renal disease or respiratory disease that do need this weight loss to reduce their morbidity and mortality risk. It would be nice to have a trial on this to prove it, and this is kind of a low-hanging fruit for an idea about the trial. And finally, another question, research question that comes up from these observations is whether weight loss response to pharmacotherapy can actually tell us how well the person will do after surgery. And this question has arisen because I think you will agree that there is a significant overlap between the mechanisms that cause weight loss after surgery and with pharmacotherapy. Let's now move on to where we could work together after surgery. We know from this work in which Ricardo Cohen was also a co-author in that even with the best treatment for obesity at the moment, we still get a distribution of response. Most people are somewhere here on the average, about 20-25% weight loss, but there will be a small proportion of people who do extremely well, the super responders, and there will be a proportion of people who respond suboptimally to these procedures in terms of weight loss. So either they don't lose any weight or they regain the weight that they have lost, or more relevant to health, they do not achieve the amount of weight loss that they need in order to improve their obesity related complication. So if someone responds by, say, 15% weight loss after a sleeve gastrectomy, which is a suboptimal response, but they need 20 or more percent weight loss to improve, say, their functional ability, then they have done okay-ish after the procedure, but they haven't done well enough for what they need. And this is the space where we could be using pharmacotherapy. Let me stress again that the mechanism of action of basic bypass and the sleeve gastrectomy is predominantly, if not exclusively, biological. Therefore, this old thinking that we have that bariatric surgery and change of eating behavior or people's habits causes weight loss should now be transferred and become obsolete and now be replaced by this new thinking in which if bariatric surgery works, then it works by actually changing eating behavior, and that change in eating behavior causes weight loss. So by adopting this thinking, we can remove the blame to the surgeon or can remove the blame for the patient for not following what they're meant to be following and just suspect that the signals through which the operation works are just not there or they're not effective. This is a very nice work that was done by Paulina Salminen and her colleagues as part of this IFSO consensus meetings where we agreed that the definition of suboptimal weight loss is less than 20% total body weight loss at any point in time, or a lack of improvement in an obesity-related complication. So we see we're bringing health in there as well, or that there is more than 30% weight regain from the original weight loss. These are a little bit lines in the sun, but I think they can help orientate us in terms of what we're trying to achieve. Now, we always have to go back when people do not respond well to surgery and go back through the usual things that can upset body weight regulation. So we'll talk about sleep and stress, physical activity, nutritional therapy, has something changed in people's lives. And if there is space to make changes there, then yeah, we should make those changes. But we will often find that there isn't much that we can change. There is a temptation to think about revision surgery. And I would say that if we were to move from a band to a sleeve or a bypass, that's probably reasonable. But moving between a sleeve to a bypass or changing the limb length or the gastric pouch size of the bypass is probably not a good idea. We might achieve a little bit of weight loss, but that comes at the price of higher perioperative complications. So I don't think this is where we should be investing our time and effort. Um, let's talk about what we can do in terms of pharmacotherapy. We've got just correlational evidence that people who do suboptimally after these procedures may have reduced secretion of gut hormone signals that cause satiety, and therefore, many years ago, that lend us to the idea of whether we can make up this GLP-1 gap in order to improve the outcomes for people that have responded suboptimally. This led to the Gravitas trial, which was the first RCT of pharmacotherapy after bariatric surgery in the form of GLP-1 treatments. And there we randomized 80 people with obesity and type 2 diabetes that had undergone gastric bypass or sleeve gastrectomy previously and had an HbA1c of more than 6.5%, i.e. diabetes relapse, to either liraglutide 1.8 milligrams, which is Victoza, or placebo, and we treated them for 6 months. And what you'll see in the results is that people lost exactly the same amount of weight loss. Remember, this is 6 months, and experience improvements in HbA1c, which are almost identical to the use of this medication, liraglutide 1.8 milligrams, in people that have never been operated before. So perhaps this can come as a surprise or not, but in any case, these are very encouraging data coming from double-blinded RCT that pharmacotherapy can be effective in people after surgery. And in fact, there's even a distribution in terms of response to the medications even after surgery. It is almost as if the medication cannot see that someone has had the procedure and it just works anyway, despite the theoretical rises of GLP-1 after these operations. Our findings were confirmed by work done at UCL, in where liraglutide 3 milligrams, Saxenda, was given to people with suboptimal weight loss response, very suboptimal, about 7% weight loss to bypasses and sleeves. And within the 6-month period, people lost about 8 or so percent of their body weight, which is probably a little bit higher than what we would expect of the effect of this medication to be in unoperated people with obesity. And again, you see this distribution of response to treatment. If you want to read a pretty comprehensive review for the use of pharmacotherapy around the time of surgery, I would say this is a pretty good manuscript. Really good data there, great work done. I am biased, of course, because I'm a co-author, but I think it's a good read. And here we've got the consensus statement from IFSO around the use of pharmacotherapy for people undergoing bariatric surgery before and after, and what are the research questions that arise from the gaps in knowledge. And some of those questions I'm expanding to now are whether medications work in an additive way to surgery or in a synergistic way, which would be even better. There are disagreements as to when we could start medications after surgery, and I can understand there are a number of schools of thought there. My personal approach is to wait for 1 year so that I know exactly what surgery has done, and then add the medication thereafter so that they know what each of the components of care has done. But you may want to be more proactive, especially in sick patients that do not respond within the first 3 or 4 months after surgery. If they don't respond in the first 3 to 4 months, you pretty much know that they're not going to respond for the next 3 to 4 years. So there is a rationale for using pharmacotherapy early in those cases. Let me also just make a point here to remind you that GLP-1s and SGLT2 inhibitors can be used for people with diabetes as not just glucose-lowering agents, but also cardiorenal protective agents. And therefore, I suggest that these medications are continued after surgery, even if the patient has reached complete normoglycemia. The mechanisms of suboptimal weight loss or weight regain are very, very much understudied. They're not easy to, but they are very much understudied. And I think this is an important opportunity for us to study them after surgery, because I would guess that similar mechanisms would also be active for when people do not respond to pharmacotherapy treatments that we have. And finally, of course, cost comes into the equation, and we need to decide who we treat and who we get both best bang for our buck with this treatment, either before or after surgery, considering how expensive. It doesn't matter how cost effective they are, but how expensive these two treatments can be, and therefore combining them, that makes them even more expensive, but potentially cost effective in the long term. That's all I have to say. Looking forward to the discussion. If people want to ask me any questions or send me any questions, they can use my email. Thank you very much for your attention.
Thank you very much, Alex. We're going to have some discussion afterwards. Now, the next presenter is Dr. Brandon Vanderwell. Despite his Dutch family name, he's a bariatric surgeon and bariatric endoscopy. He doesn't come from the Netherlands, but from Seattle, Washington. Please, his presentation will be about the endoscopic options to treat obesity, the endobariatric option.
Dr. Brandon Vanderwell. I am one of the bariatric surgeons here at Aviva in Seattle. And today I'm going to be talking to you about endobariatrics as part of a multimodal approach of obesity and metabolic centers of excellence. So I am actually now, this week marks my 6th year of practicing endobariatrics. I started doing endoscopic sleeves 6 years ago. And it's been a fantastic thing for our practice, and I can't wait to share what our experience has been and some of the highlights of adding this to your practice. So I'm a consultant for Boston Scientific and Intuitive, obesity and metabolic centers of excellence. So what are we looking for from our centers of excellence? They're looking at places that really treat obesity as a multifactorial disease. We need comprehensive care, nutrition, psychology, exercise. And we need the full complement of treatments for obesity, medications, all the different surgeries, revisions. And that's where I think when people come to us and they're really struggling with their weight, they want to know what their options are, because not every option is really is attractive to patients, because everyone all have different needs. And I think it's our job as physicians that are taking care of them to listen to them and to understand them and to really meet them where they are and meet their needs and what they're looking for. So I've made this graph here. It's invasiveness on the bottom, certainly rightward more is more invasive, efficacy, more weight loss going upwards. And this is where the anti-obesity medications, they really fit in as, not super invasive. And the efficacy is pretty solid. It's getting better. Their new medications are getting better and better all the time, but they have major limitations. Their weight loss isn't as good in real life. They're when you stop the medication, it's really challenging to maintain it. I describe these medications sort of as a software upgrade. And when you stop that software, when you stop subscribing to that software, it's really challenging to continue performing at the same level. So what most people have traditionally understood as the next option, you have to cross the anesthesia line. So you're looking at now getting a procedure, getting anesthesia, getting put to sleep, and going to have some sort of recovery. The least invasive thing that we really have in the modern era is the laparoscopic sleeve gastrectomy. And then it moves on to the more metabolically active operations of the gastric bypass, the SADI, and the BPDDS. Of course, I know there's a host of other ones. This is an IFSO talk, and there's a great number of things out there, which is fascinating. But these are the mainstream ones. And as we keep going to that far, as we keep going right on this graph, it does get more invasive, and there's more, I like to describe it as drama that patients have to be prepared to, to potentially have to live with. Laparoscopic sleeve is a pretty low drama tool, but it's not as efficacious as the gastric bypass or the SADI, and certainly not as the BPDDS. But each of those steps of invasiveness and of metabolic activity does come with it more risks and more costs other associated with it that are more than just the weight loss part. So there's this big space that when you look at this graph where there's incisions and organ removed or organ rearrangement operations that is demarcated by that orange line-ish there in the center. And there's a lot of patients out there, tens of millions in the world, that are like, I need something stronger than the medications. They haven't quite worked as well for me as I want, or I haven't tried them, or that's not really me. But I'm not really at this place in my mind where we want to embrace something where I'm getting incisions, removing a part of my organs, or majorly rearranging something in a non-reversible way. And this is the space where there's a big opportunity, and where endobariatrics is really filling that void now. And it's great because we have some really cool options with endobariatrics that's really meeting some people where they're not really at that next step to take, that is something that would potentially be really good for them, but they're just not there yet. What is endobariatrics? So this is an endoscopic procedure to help patients lose weight and manage weight-related complications. The modern primary endobariatric procedures, we have the intragastric balloons, some sort of gastric remodeling with a suturing device. Less used or off-market things now are transpyloric shuttle, aspiration therapy, and then we have the endobarrier, and then duodenal treatment options, which are endobarriers and DMR, duodenal mucosal resurfacing sort of therapies, which are very exciting. But for the purpose of this talk, we'll highlight that the endogastric balloons are certainly an option. There's a lot of different ones that are available across the world. And these are really helpful and can be really helpful for a lot of patients. It is sort of software. It's the closest thing we have to our software upgrade, because it is sort of like a software subscription. You get the balloon in there, you feel more full. And then after about 6 months or so, you generally have to take them out. It's challenging to, just like anything, if you don't rearrange the hardware, if you don't make some sort of change on the hardware, it's hard to maintain that success. And we do see that, with the medications, and we see that with balloons too, but they can be really helpful and can be for the right people. The most common suturing procedure from the stomach is the ESG with the Apollo overstitch device, which is what we'll mostly focus on because by far and away it has the most amount of data and is the most widely used. There's also the revision procedures. So this is TOR, trans-outlet oral reduction, where you can overstitch the large gastric outlet of a gastric bypass, and endoscopic sleeve dilations for dilated large sleeves. These are great options for patients that are, looking for some help after having had a previous bariatric surgery. Really great for giving them the next tool, if you will. And it's very helpful for really getting them back on track. And we'll talk a little bit about these as well. So what is the endoscopic sleeve gastroplasty? It's the endo sleeve, the accordion procedure. It's an endobariatric procedure, first performed in 2012, hundreds of thousands performed. Usually use the Apollo overstitch. The technique that's critical with this is that you have full thickness bites through the stomach that are well placed with a permanent suture. This is a video that I took of a overstitch device that I used. I did LSGs and some ESGs in the same day, and you can see here you have used that overstitch device on the sleeve specimen of an actual stomach to put full thickness bites there. You can see that those full thickness bites, you can really can see them if you do take good bites. And then what you're going to do is you're going to cinch those together using essentially 2 T-locks on the end of those and lock that tissue together. And it's going to crumple down in sort of a plication, similar to the way I like to think of it as like if we do a really good job with this, you can see what that's cinched really well. It's going to approximate that tissue really nicely, bring it together really well, similar to the way we do like a fund application or application around a band, which when done really well have the ability to be permanent interventions on the stomach. And this is a great example in this picture of, well-placed sutures, cinched well, have a really great, that's a fantastic anatomic intervention that's really going to help that patient now and be durable long-term. The first two, ESG was described in 2013. And then, we now have 5-year data that is showing strong weight loss maintenance results with the ESG. This is Dr. Sharaya's data showing around 15% total body weight loss at 5 years for her patients. And these were remember, these were early patients. Every year, I think we continue to get better at this procedure and get better at doing it, get better at maintaining it, but get better at helping people use the tool effectively. So the randomized controlled trial data, the MERIT data, showed that the ESG was better than placebo and was really helpful in getting this approved for FDA approval in the United States. 3,000 patient plus from Dr. Al-Qahtani's data in Saudi Arabia showing effective weight loss with non-inferiority compared to laparoscopic sleeve with good safety data and a very valuable intervention and very safe. So he had his ESG data was 14% total body weight loss versus 19% at 3 years, which was showed a really good set of data for this procedure. ESG in class 3 obesity, here's a paper about that showing 20% total body weight loss maintained at 36 weeks with a minimal serious outcome event, and which is just furthering the data of like these are really valuable interventions and they're very, very safe, which is really what patients are looking for. They're looking for that, I really want to make some progress and I really want something that's very safe. There's an IFSO positions statement now paper on endobariatrics being a approved procedure that, and then we've just actually recently voted on a bunch of position statements on how best to use it, which is exciting. So meta-analysis, thousands and thousands of patients showing that excess weight loss is looking at 45 to 55% in the excess weight loss standpoint, and then in the 15 to 18% total body weight loss for these articles that were queried. There's some exciting things kind of coming down the pipeline. We're looking to try to be even more aggressive to try to bump up that total body weight loss on an average standpoint. They're doing potentially third space, ESG in third space, to really get better tissue apposition, get better scarring that really helps the stomach grow into a newer, smaller shape instead of just putting mucosa to mucosa surfaces together and serosa to serosa on the outside. The ESG plus gastric mucosal fund ablation, been a procedure that has been actually done across the world now, showing increased total body weight loss in the mid-20s, 23 to 24% total body weight loss, which is a really interesting opportunity to really continue to grow this space to get it better, really meet the needs that patients have, because they're looking for something as effective as it possibly can be while being very safe and having a good recovery, easy recovery. The ESG and GLP-1s, and truthfully, like if we're really honest with ourselves, in almost everywhere in the world, GLP-1s dominate our field of obesity. And I think it's really important that we don't get into the, well, this or this. The future of obesity care, the future of every care, cancer particularly has been doing this for decades. The future is and it's how do we use this therapy and this therapy and this therapy and this therapy, similar to the way that we've been using nutrition and psychology. I think that we should embrace using anti-obesity medications as quickly as possible in the surgical journey as well. This is, if you want to compare the ESG versus, it's, when people are thinking, well, should I do this, maybe semaglutide versus endoscopic sleeve. Endoscopic sleeve actually shows better effectiveness and better cost effectiveness at 5 years compared to just a GLP-1 alone. But really, where the truth lies, where the rubber lies, is which is endoscopic sleeve and anti-obesity medication. This is with oral semaglutide, showing improved results in total body weight loss and improvements in decreasing A1C reduction, 1.4 versus 1.2, and total body weight loss or excess weight loss went from 62% to versus 52% in the non-oral anti-obesity medication. With injectable semaglutide, the results are even stronger. We see better total body weight loss with, exceeding 25%, 28% here at 12 months versus less than 20% at 25%. This is 12 months versus less than 20% for patients that just received ESG alone. I think that's really an exciting development because patients are looking for the best combination of therapies that gives them the best result and still has a very acceptable, lifestyle and side effect profile and cost effectiveness. You can see here, this is some great data coming out of that. This is our own data here in my practice at Aviva. This is our patients with a BMI of 30 to just under 50, and this is comparing we describe it as a normal stomach injectable GLP-1 semaglutide versus tirzepatide, and endoscopic sleeve, gastric sleeve, and gastric bypass. And this is patients at 1 year showing over the last few years that show a significant, a really strong result. And also you see the biology of these procedures and how the biology really does matter about how much you're intervening on that biology. The endoscopic sleeve, the beautiful thing about it is that it's not overly aggressive. That's what patients really like about it. And you can see that it has a great profile of, solid total body weight loss in the low 20% in our practice, but that's versus the 30% that we usually get for the gastric sleeve, laparoscopic sleeve. So it's a really cool tool that really gravitates to a lot of patients. But this is the biggest fear that a lot of practices have, is that endobariatrics is going to pirate their bariatric surgeries. If they start doing endobariatrics, they're going to lose all their sleeves because all their sleeves are, oh, I want to go to that one. And here's what happened in our practice when we started this 6 years ago. So in our first 2 years, we did 469 consults that distinctly the patients said to us, I'm really interested in your endoscopic sleeve. I saw that on your website. I want to know more about that. I didn't. And we had a very consistent messaging, which is, it's a new procedure. It seems very effective. It seems effective and seems very safe. If you're willing to undergo laparoscopic bariatric surgery, you should seriously consider it. And here's its safety profile. We've been doing bariatric surgeries for almost 15 years at that point, 20 years now, and it works very well. It's very safe. It's a really great tool. And in that conversation, 177 patients went on to get their endoscopic sleeves, but actually 107 went, oh wow, I didn't realize that this is actually what a laparoscopic sleeve is, and it's much safer than I thought it was before. And they actually went on to get laparoscopic sleeves and have done fairly well. The ESG patients still did great. 23% total body weight loss in this cohort at 1 year. Major improvements in hypertension and type 2 diabetes. The TORI is the major revision of choice for gastric bypasses, and this is a great operation for helping people just get a little bit more jumpstart, where you ablate the gastric outlet of the gastrojejunal anastomosis, as you can see here in picture B, and then you use the overstitch to go in usually a circumferential pattern and tighten it over the balloon about 6 to 8 millimeters in diameter, and it scars down really nicely, giving patients a little bit return of the speed bump of that anastomosis. This is by Maselli and Dr. McGowan. Their total body weight loss for patients was a little bit above 15%, which was really strong. Great for helping these people get back on track. This is Dr. Jarapino's data from Brigham and Women's, and this shows around 9% initially, 8-9% at 1 year, and then is able to maintain that at 3 years. And these are really great tools to have in your toolbox if you have a comprehensive bariatric program, because you're going to have obesity is a chronic disease, and we're going to have patients come back to us and needing a little more help. And this is a great tool to help them, give them a little jump start. So, in conclusion, thank you all for listening. And I hope you really consider that endobariatrics is a great tool to have as a multimodal approach in your centers of excellence because it gives more tools, more revision options, better outcomes between in that space between surgery and medication, and it's also going to open up the conversation for you to have more surgery from your regular bariatric surgeries than you would have otherwise. So. Hope you guys all are having a great little meeting and looking forward to the question and answer.
Great. Thank you very much. We have all the speakers back on screen. I'd like to introduce, besides Brandon and Alex, Michelle, Shelley Vicari. She's replacing for the questions and answers the presenter, James Zervios. He's absent for a personal problem. Shelley is the director of programs of Obesity Action Coalition from the United States. Thank you, Michelle, or Shelley, to be available to join us. While we wait the questions from the audience, I'd like to ask Shelley. You saw the two experts presenting the options. You haven't heard about surgery, but you heard about combinations, you heard about endoscopy, and surgery so far is as effective as medication, but we have long-term data, while the medications don't. I'm a pro obesity measure medication surgeon, and I was the first author of the two papers that Alex showed. So you, as a patient representative, what do you think about the options? What would you jump in if you have these safe and effective options? One is durable, the others two are not. So what do you think about this balance?
So, as a patient, I myself, I'm a person affected by obesity. I had bariatric surgery in 2006. I am currently utilizing that obesity medication to maintain my weight, and I embrace the more options, the better. We're individuals, and we have different lifestyle needs, as Dr. Vanderwell said. And the more options on the table for us, the better. Insurance coverage, affordability, safety, all of those factor in, as well as lifestyle and what works for you versus someone else. Just having all those options is a wonderful thing. At Obesity Action Coalition, we have a piece of education that we provide, very agnostic look at all of the different availabilities called Understanding Your Obesity Treatment Options, sort of breaks down the science that was shared here today in a very patient-friendly way. And so it sort of gives the pros and cons and things that they can then bring back to their doctor and have that discussion that Dr. Vanderwell talked about, what really works for them and ask questions that sees whether it fits into their lifestyle.
So to make a long story short, the more the options, the better for patients,
The better. Right? Absolutely.
Right. Brandon, IFSO just published about 2-3 weeks ago a position statement on how to improve the management of the endoscopic sleeve gastroplasty. And yes, medications are there. Maybe the interim administration of medications may be a good option with the endoscopic sleeve gastroplasty. Unfortunately, so far, the IFSO position statement, which I'm the senior author, we recognize ESG as a good option. However, we'll still need a lot of data. We have only one trial, RCT, the MERIT trial, and the rest is a collection of retrospective and prospective data. It's promising, however, we need robust data. The same with the TORI. Restriction is not exactly a mechanism of action of any weight loss intervention. So semaglutide, tirzepatide, the upcoming retardatide, orforglipron, they don't add restriction. They have physiological mechanisms, as Alex mentioned. So what are your thoughts about the real use? So the people who are listening to us, ESGs is a good option for patients with high risk, for example, or for patients who do not want to undertake surgery because they don't want surgery. This is the main cause of people who do not undergoing surgery. So what would you tell the audience on how to approach your patient when you have ESG as an option? I agree with you, all comprehensive centers for obesity treatment should have ESG. Straightforward. Do this, and that, like a recipe. What should you give them?
Yeah, it's a great question, Ricardo. No, I think it's my conversation with patients when they ask me, what should I do? It's pretty simple. And that is, if you're willing to undergo a surgery, one of the bariatric surgeries, you should seriously do it. Like they work really well. They're the most durable treatment that option that we have for sure. Um, and honestly, like you want to do that and medic and a little bit of medication. And what's cool about, I think what people don't really realize is that after surgery, in ESG included, in this surgery moniker here, is that the amount of medication that you need to use is so much less for almost everybody. Like I usually will drop people by half to a third with their medication stuff, which I think is physiologically showing us how much biological effect the procedures are having. But also, I don't know what what particularly Dr. Miris's thoughts are on this, but I think the less medication someone uses, the better, because it's going to give them the most chance to get off of that medication to be without it. And I think, physiologically, nothing that we've ever done, is for free. In any therapy, as you can see on that curve of increasing invasiveness from the surgery standpoint, it comes with extra stuff. And I think the more we're pushing the physiology of things, the more downside there is. From the ESG standpoint, I say if you're not really willing to do surgery, and I have people in my, that I know in my own life that are like, I know I need some help, and I just surgery's not where I'm at. If you're not willing to do that, I tell them seriously consider do the ESG, hands down, no questions asked, don't lose a minute of sleep over it. It's a really good tool. It's very helpful. It's like very low risk, very low drama long term. It can be really help people go in the right direction. And you want to do some medication too. Like using those together is fantastic. I think that's just like cancer treatment has really embraced, you know, full treatment algorithms with, surgery being the mainstay of a lot of them. I think that is probably where obesity is going to head future. If we get the right, look at the data well, get some really good studies that collaborate both of these things together. But no.
Great, thank you. Alex, I have two questions for you. The first one is, why do you think we have a race for weight loss with the drugs? For example, I'll give you an example. And you know better than me, 20% of total body weight loss solves 95% of the problems of obesity, the complications of obesity, and even it solves most of the illnesses that comes with obesity. So this is the first question. Why do you think the race? Because retrexal will come with 30% of total body weight loss. And probably in the pipeline, we have drugs that will deliver more than that. Do we really need that? That's the first question. And the second one, with those potent drugs in an ideal world where costs will decrease, because it will. The first statins cost a kidney when they were launched in the market. They don't cost that anymore. So do you think that surgery, I don't mean it will die, but it will have a very limited role as cardiac surgery? So there are two questions: the race for weight loss,
I'll start
the
with the
need for
second.
surgery.
I'll start with the second one and say that this we need to move away our thinking from aiming to start the medication and stop it. Now, I appreciate the financial constraints make this a temporary problem, but it is a temporary problem. It will be solved. It might take a bit of time. It is already being solved. It will be solved. So this thinking that we start and stop medications, we should start to get away from, in the same way that we don't say that after 2 years, we're going to undo the ESG, right? And make the stomach as it was before, if we could, or undo the gastric bypass. All of those treatments are there to stay. So I think that what will happen to surgery, Ricardo, I think I don't have a crystal ball, but I would say that we're going to be needing surgery over the next 10, 15 years for sure, for many reasons, including the fact that medications have side effects and some people don't respond adequately. Therefore, these are the people that will go for surgery. Will surgery have a limited role? No, but you will be treating sicker patients or
We
patients
are
of
already actually. We
yeah,
are doing.
and I think that might get worse. So sicker patients, higher BMIs. What will happen if I don't know what will happen in 50 years if surgery will still be around or not. I don't know.
We
But
won't be around that, which is good.
we'll see. But for the next 50, 20 years or so, I think that the operations will just get more difficult because of the kinds of patients that you will be getting. Now, I think your first question is directed towards what is our target, right? Treatment
Exactly.
target.
Exactly.
And
Why do we need 38 total body weight loss?
and I'm not sure that we still have got the answer to that, that we know what our target is. I know that a lot of complications will improve after with a certain percent of weight loss, even 20%, but I think that we cannot necessarily extrapolate that to people that are heavier or people that are sicker. Okay, so I for now I get the weight loss race until we provide companies in the wider world of obesity for specific targets that we're trying to achieve. Then this is still worthwhile, because say that our target is a BMI of 28, which is an absolute, right? Not a percentage, but an absolute target. If someone starts from a BMI of 60, then the weight loss percentage matters, because if you're trying to achieve a specific target. But if it is all about relative change, percentage change, again, the discussion might be different. So I'm a bit vague, because I don't think we have a clear target that we need to be aiming for. Therefore, starting with weight as the most basic of measurements, not racing necessarily, but having it as the most basic of measurements for now is helpful.
What do you think is more important, health gain or weight loss?
Well, certainly health gain, but the problem is that for some conditions there's a direct relationship between the health
Perfect.
gain.
They're less than 10%, maybe HFpEF, maybe
Yeah,
osteoarthritis. Yeah.
and
So
what we recently found from our Bambini randomized trial is that there was no limit for the improvement of ovulation in women with PCOS. There was a direct line, a straight line. So that's why I think weight loss still has its benefits, a percentage weight loss, but
but secondary.
certainly, yeah, exactly. We should not be obsessed about it.
Great. Shelly,
I would
you as
agree, Dr. Cohn. I would agree. As patients, we have so many different needs, right? I mean, some of us just want to get down on the floor and play with our grandkids. Some of us just want to, be able to have a baby, and have had difficulty. Some of us want to, I one of my goals was, my mom was 70. We would walk the mall, and I would take more breaks, on benches than she would. At the time. So, my goal was to keep walking, and ended up walking across the Brooklyn Bridge, and doing things like that as goals for myself. So,
health gain
we
was the
are really
purpose.
individuals. Yeah.
Great, good. So we have 1 minute left. So Brendan, and then Alex, and then Shelly, your last comment on the new era of treating obesity. It's, yes, of course, it's a multimodal age. This won't go backwards. It's everything together for the best fit for our patients. So please, Brendan, and then Alex, and then Shelly, your last statements on this very good webinar. Really very, very interesting.
I think the future is
Brendan.
it's medication and surgery and, and nutrition and psychology and exercise. It's and. Um, the I think what's really interesting is that if we look at the numbers, if you have tens of millions of people on these medications and only even just conservatively a 15% dropout or poor responder rate, and you only do surgery on 20% of those people, you're going to quadruple the amount of surgeries that you do. So,
Alex, your thoughts?
I'm just very pleased about what the medications have achieved in terms of narrative.
The awareness.
They have completely make people pay attention to obesity. That's the major benefit of what medications have achieved. So which is good. And people sometimes say, well, we shouldn't be medicalizing obesity. I would disagree with that. I think we should be medicalizing obesity, because if we say it's a chronic disease, when it needs treatment, right, then it becomes a medical problem. And what medications are doing is that they are bringing people into this medicalization sphere. And that then allows us to explore all of the other opportunities, including endoscopic, behavioral, psychological, surgical therapies. That's, I think, the major benefit of what we have achieved in the last 5 years only.
Perfect. Shelley, please.
I would say it's exciting times for patients to have all the different options that are out there. It is a chronic relapsing disease, and the more that gets out there, the more the science gets out there, the blame and shame and stigma will reduce, we hope, and we work towards that with the Obesity Action Coalition. One thing that I would ask clinicians that are listening today is to try and eliminate the use of regain, the word regain, and start using recurrence. If it's a chronic relapsing condition, that sort of takes the stigma out of the patient responsibility in that regain, right? It happens. And so I'd ask for that. And just really exciting times and wonderful options are coming for patients to address this disease.
Perfect. Thank you very much, Brandon, Shelley, and Alex, for this outstanding webinar. Thank you to all that listened to us for the past hours, and see you next time. Thank you.